I'm Dr. Ira Kirschenbaum. I am the editor-in-chief of the Journal of Orthopedic Experience and Innovation. Tonight, we have an exciting event that has been sponsored by Ospitec, who I feel is quickly becoming a leader in a space of episode of care and efficiency and a wide range of things you're going to hear of tonight. And the name of this talk is, What is the Drumbeat of Your Patient's Journey? I am going to start by asking all the our panelists, our guest panelists, to introduce themselves. And we'll start with Dr. DeCook. Just a brief introduction for all of you so everyone knows who's who in the beginning, okay?
Great. I'll start off. This is Charlie DeCook. We're happy to be here tonight. I'm a total joint specialist in Atlanta, Georgia. We have a group of 16 adult recon fellowship trained folks that operate in ASCs, and we've used Ospitec thoroughly to help improve our efficiency.
Excellent. Emily Arce?
Sure. My name is Emily Arce. I'm the director of the Total Joint Centers here, and I really appreciate the time that everybody's given me.
All right. Lacey, you want to introduce yourself, please?
Hey, good evening. I'm Lacey Dyer. I'm VP of Clinical Operations for Surgical Investors and Advisors, a management company. A nurse trained, but I'll tell you, I've been trained by the best orthopedic surgeon ever, which was my dad. So lots of time spent learning this profession.
Oh, very good. And John Bring, you want to say hello?
Yeah, I'm John Bring. I'm the VP of Innovation and Outcomes at a orthopedic specialty hospital in Omaha, Nebraska. We have 12 ORs, and this year projected to do about just over 14,000 procedures this year.
Wow, that's a lot. And Dr. Sanjay Ghosh.
Yes, sir. Yeah, my name is Sanjay Ghosh. I'm a neurosurgeon. I went to University of Michigan for undergrad and med school, Go Blue. And I did my neurosurgery residency and spine fellowship at the University of Southern California. So I will be schizophrenic when USC plays Michigan this year coming up. And so I'm one of the early adopters of Ospitec. One of my business partners, Dr. Batra, came up with the idea, and then I really, was intrigued at what a great solution this was. And what a great tool this was. And so I've been involved with Ospitec from the time that it was just, kind of a concept on a slide. So happy to share my experience.
This is superb. So we're going to start tonight with Charlie DeCook, who's going to present a discussion essentially on the drumbeat for the patient journey. And Charlie, I'm going to hand it over to you and whatever you need to do.
Awesome. Thanks, Ara. So unfortunately, I'm going to just lecture for about 8 minutes, and then I'll be done and we can get lots of conversation going. But really, I want to talk not specifically about any particular product, but really how we built an efficiency machine. And I hope that that will be helpful. These disclosures are all relevant. All of the things that I do, I look at from an efficiency perspective and the ownerships as well. So real quickly, there's a lot of joint surgeons on this call. So I think we got to dumb this down a little bit into the fact that we're all having reduced production of professional fees. And to do that, we have to somehow increase our revenue in some way. For us, it's been a no-brainer to do more cases. The key is if you can do more cases in less time, that is the key to efficiency. And that's what in 8 minutes I hope to do for you. Hospitals around the country, ASCs around the country use OR utilization, which is a perfectly ridiculous metric that you should throw out. So however long the surgeon or the patient's in the room versus the available time means nothing to me and means nothing to the revenue that we make in our center. So try and throw that out. We want you to think about throughput efficiency. It's a very simple metric, and it's very simple. It's the number of cases you can do in a particular OR per day. That's throughput efficiency. So a total joint specialist, it's very simple. Our number is 10. It's easy to remember. In every OR that we have, we want to do 10 joints in that room per day. efficiency, 10 joints per room per day. That's our throughput efficiency. So we have a bunch of 2-room ASCs around the state of Georgia here. So that means that in each center, I have the possibility of doing over 7,200 joints a year. Now, this last year, we did a little over 3,200, which means our efficiency was around 44%. That means with 2 rooms, we could do 3,200 cases, and we're still only 44% efficient. So throughput efficiency really is the key here. Now, this gets down to the very definition of efficiency itself. The very definition of efficiency is what? It's output over input. That's as simple as you should think about efficiency. What are the number of joints or whatever surgeons are on? What are the number of cases you can do in a day? Remember to begin with the end in mind. I think we cut ourselves short and don't realize how many cases we can actually do in a day if you're in an efficient place. And then dial back from that and say, what is the number of staff and supplies I need to make that output happen? So this applies to throughput accounting. So we look at financials much differently than a hospital or ASC. We focus on the output. We focus on the numerator. What are the number of cases we want to do in our center? And then how do we divide that up? How do we throw the number of staff and money at it to make that happen? That's how the world goes round in the operating room. So always remember, it's not about cost accounting, which is the reason why you're always understaffed, because they have a certain limited budget of OR nurses, circulating scrubs. All those things are limited because they look at it from a finite denominator perspective. They say, this is the amount of staff and money you get, and that's the limits of what your output are. The thing you have to realize is that you choose where you're going to do your cases. So you have to pick a factory that works, right? One of those principles is the theory of constraint. This is probably the one that's helped us the most in our ORs. And obviously we know the constraint is the bottleneck. It's the point that restricts the overall capacity. So your job is to find out where the weakest links are in your chain and identify that constraint. Once you do that, you really have to assess how effective that constraint is. So if we're making washing machines, and this is my machine that makes those washing machines, I have to assess how effective it is at doing that. Once I do that, I can really exploit the constraint and make it more and more productive. That's the basic principle of the theory of constraints. And a lot of people always blame the anesthesiologist, which is not the constraint. And believe it or not, it's not even turnover time. That is not your constraint. The constraint in the system is actually you as the surgeon. You are the rate limiting step. That surgery cannot happen without you. And your operating room and ASC needs to appreciate the fact that you are the constraint in the system. To exploit that constraint, what we do with our surgeon is we throw the number of staff, supplies, and money that we need to increase their output, because we realize that the surgeon is the constraint in the system. And this gets to the heart of what the title of actually tonight's webinar is all about, is drum buffer rope theory. And it's a very simple theory. And that is, once you've identified this constraint, you have to give it enough buffer. So remember, the surgeon is the constraint in the system. The buffer is a patient that is prepped and draped in that OR, ready to go. That is the buffer in the system. That patient has to be ready to go. When you walk out of one OR into the next OR, that patient has to be ready. In order to do that, there has to be a drum beating. And we all know about that drum beating. That's you yelling at someone to bring the next patient back, yelling about turnover, yelling about the inefficiencies. But you have to change that drum beat to something that's automatic. And for us, that's been Ospitec. That drum beats all the time now because we have Ospitec in the background. So the drum is beating when that patient gets there. I have to have them beating to go back to the OR, to the PACU. When I see them in the recovery room, that drum has to be beating, and I have to get that patient in and out of my ASC in 3 hours. To do that, we have to be efficient, and we have to deliver everything just in time. So what Ospitec allows us to do is get that patient to arrive exactly when we want them to arrive, right? We tell them, we don't tell them any longer to go back. Ospitec tells them to go back to the OR because Ospitec knows exactly how long it takes me to get ready for that case. Same with getting a patient out of the PACU and working physical therapy. That drum is beating all the time. Another concept I think that's really important is this idea of work breakdown. This came up for NASA when they were trying to put men on the moon. And they realized that they had a complicated task that had to be done, and they had to break it down into individual steps. And no better example of this is Formula One racing. When you think about what happens in a pit stop, how work breakdown happens, we look at each individual step and say, how do we improve that one individual step? The problem is all of us surgeons, we look at these big problems like anesthesia or nurses or your OR culture. And the problem with that is it's too big of a problem to fix. You have to break down those individual things and make them into small things that you can actually fix. So we break down those things. Each process gets break down into tasks and actions. And then most importantly, we measure those actions. If you are not collecting the data of time in your OR, you're never going to affect any change. And that's what Ospitec does. So we set expectations in our operating rooms. We can do that because time is always present in our OR. And for us, our expectation is a patient's the OR room is ready in 10 minutes. That's our expectation. Now, how do we do that? Well, we have to have new innovative things like SteriCube or other things that allow us to do things that we couldn't do before. Because when we looked at traditional blue wrap, it was taking us somewhere between 20 and 24 minutes to get ready for a total knee or total hip. That was too long. What does SteriCube do? It cut it down to less than a minute for us. And the same thing in SBD. It's helped us focus and realize all the extra time we're spending on blue wrap and all those things that SteriCube solved for us. So when you break down individual processes, you try and find the new innovative solution that will work. And for sterilization, it's a no-brainer for us. SteriCube has been able to do that. And one of the last concepts is parallel tasks. So this is our operating room opening for a case. If you look at the number of people in there opening, there's a SteriCube coming in. The number of people in there, we are putting more staff in the room because we know we need that to get 10 cases done in each OR per day. So that's what an opening room looks like, right? Same with closing. When someone is closing this knee right now, I'm dictating, I have 2 assistants closing, and look at all the people helping me get ready for the next case. They're breaking down everything even before that wound is completely closed. That's the idea of these parallel tasks happening, and that's what we've done with this efficiency machine. And I think with that, I'll end.
Wow.
Hopefully, stop sharing.
Wow.
How'd I do my time? Good.
Great. This is phenomenal. A couple of things.
Yeah.
First of all, again, if people have questions, please put them in the chat. I think that'll go a long way. I'd like to move it around, and Lacey, give us a little talk about operations. And there must be an operational magic and secret sauce going on here in this.
Yeah,
maybe it's not so secret because Charlie just opened the hood for us to look underneath.
There you go. Well, a key part of that is expectations. I think that that is key for any center to, understand that the expectation is we're going to get this amount of cases done. And nurses have to change their thinking from the hospital thinking that another shift was going to come on and take over, and it really didn't affect their work day. In the ASC, we see, they're motivated. We want to get those cases done, and then we get to go home. The other piece that we want to make sure that the surgeon is starting his day on time. So we do everything to prepare those rooms the day before. Certainly having some standardized equipment and processes in place makes that happen. We also evaluate, what time do we need to get the patients in the facility, and then sequence those patients appropriately. So we do a lot of time studies on per surgeon, anesthesia. We monitor all of them individually. We can say which doctor, which anesthesiologist, what those times are. Then, I have an old-fashioned way of doing staffing. Everybody talks about FTEs, never liked it. I talked about touches. So how many people touch that patient? And is it a nurse that touches them? Is it a tech that touches them? Where are we? So we staff that way. We cross-train our pre-op and PACU, keep them in the same bay. The pre-op nurse PACUs those patients. We certainly give enough time for people to be able to get a break and do those kind of things. But those are some key pieces. When Dr. DeCook talks about the bottleneck, for us traditionally has been the PACU bays. So we spent a lot of time working on how are we going to efficiently move those patients out of the facility? What is their recovery time? What's stopping recovery time? What's impeding those pieces? So those are some key things that we've learned, and then we've taken it in our company to other specialties. It's really looking at measuring time and really honing in on what's being done each day.
You know, a few things just to emphasize there, Ira, is
Yeah.
first of all, the definition of start times, right? So a lot of us say wheels in is the start time. That's a terrible metric to have, because the average time from in the room to cut time is 47 minutes. So your start time should be your cut time, whatever that is. We've never had a late start in our ASC, and that's because of quote unquote culture. The other thing is our staffing model is super unique in that we think that there should be a team that's there, that's in charge of cleaning the room, that's in charge of that room, and there's a team in charge of the patient. So for us, it's the anesthetist, the circulating nurse are in charge of that patient. They have to worry about taking that patient out of the room and getting the next patient. Meanwhile, we have enough staff so that the scrub tech has enough people helping with the SteriCube to be able to open and to be ready to go. And the other interesting thing about staffing that we have is we have it kind of on demand. When they see that they're behind in one room, they'll get 1 or 2 scrub techs scrubbing in to get ready, because sometimes they need to go really fast and get things ready to go and turn over in 5 minutes or something like that. But they are aware of what's going on in those rooms, and they each help each other out to do that.
That's great. I think that a number of questions are coming through, but I'm going to hold off on them a little bit until we get everyone of the speakers chiming in. John Bring, you've seen this in action. What about replicating and implementing? That is clearly a science behind that?
Yeah, I think we've been on a bit of a journey to get to a more mature state that Dr. DeCook and Lacey have been talking about. And when we first started, we couldn't answer some of those questions of, how long could it take? We considered ourselves efficient, but as we started talking about our growth and doing things at scale, we realized we did not have all the details that we needed outlined. And so we had to spend a lot of time answering those questions, creating those expectations. But now that we have a lot of those things outlined, then you're able to plug it into a tool like Ospitec, and that's really an accelerator for us. And then we're looking even beyond our walls today, then of how do we take that into different environments, a new ASC, and be able to use that as an overlay to move things a lot faster and maintain that consistency and that rhythm, no matter what environment we're in.
So let me ask Sanjay, you have been using this for a long time. In your sort of what I'm going to ask you to do, what your results have been over the years, explain Ospitec and what it is, because I think what does it actually do for you, and you've been a long user of it. So what have your results to date or over the years?
Sure. So the genesis of Ospitec, I've been in surgery 7 years as a resident and 22 years in practice, so nearly 30 years. There were 2 facts of my existence as a surgeon that I found extremely annoying. First, there was never an easy way for me to know where my patient was. So if I'm in the surgeon's lounge, I'm trying to figure out where's my patient in the process. Are they in the lobby, in the pre-op hold? Are they actually in the OR? Where are they? There was never an easy way to figure that out. I would call the front desk. Nope, not here. I'd call the nurse's station. I'd call the OR. Finally, I'd have to get up and go and walk around the center to find my patient. And so I thought, that is ridiculous. And so that was my first irritation. The second irritation is the hospitals in particular are unbelievably inefficient. So I would do a 30-minute minimally invasive lumbar microdiscectomy, but it would be, it would then be, and if I had 2 cases, I would have an hour and a half to 2 hour pause in the action. So I would end up doing 60 minutes of surgery and 120 minutes of waiting. And the hospitals didn't seem to care, nor did they have a method to really track operating room utilization. I was shocked at their inefficiency. So Ospitec is an extraordinarily elegant but simple way to track the patient throughput through a surgery center by use of a smart patient wristband. And so I'll explain it a little further. It's useful to think about adoption of technology. Ospitec is such a simple, it's as simple as putting a wristband on the patient. And by putting the wristband on the patient, you get real-time tracking of where the patient is along the journey, second by second. And in doing so, you also get real-time data on your ultimate inventory. That's operating room time utilization. So the way it works is the patient checks in, you put this smart wristband on them, and then that smart wristband pings through the center using Bluetooth technology. And so when the patient goes into the pre-op hold, the sensors detect that, and it populates that they're in the pre-op hold throughout the whole center, and then it's displayed prominently, on centralized television screens throughout the surgery center. Nobody has to do anything. It's detected, and there it is. Now, when the patient gets into the operating room, the nurse wheels in, and there's just like a iPad or a tablet on the screen. They say the patient's entered. So now it populates throughout the whole center. The patient has entered the room. Once the patient's intubated, you touch the tablet now. So now the patient's intubated. So at any point in time, the operating room manager, any surgeon in the lounge, anybody in SPD can get immediate real feedback on where the patient is in the journey. And so all of a sudden, it's not like I'm not getting up. I can look up at the screen, or the operating room manager can look up at the screen and says, okay, in these 6 rooms, I have these people at these exact stages. Now, really the greatest thing is it's so easy to adopt. It's not complicated. It's extremely easy to adopt. And then what you get then is you get real time on every step of the process. And when you get real time on every step of the process, and you have measurements, all of a sudden you have trendable data on how long does it take Dr. Smith to do the total knee versus Dr. X. And then you can actually really plan for efficient operating room time utilization, and you can detect bottlenecks because you have real data. And you can say, okay, well, look, after a certain procedure, we're having a particular delay. So how do we correct that? So it's a simple, elegant solution that's easy to adopt in any surgery center. And it gives you visibility on where the patient is in the journey. It automates that process, and it gives you invaluable data so you can optimize your most valuable resource in a surgery center, your operating room time. And I've not seen in 29 years, I've not seen anything like it. And I think that the reason it's so effective is because it's so easy to implement.
It's great. There's a lot of questions that are coming in, and we're going to handle them. But I'd like to put the most important person on the spot here, Emily Arce, who's a nurse.
Great.
What is the nursing perspective on the delivery and executing this outcome and optimizing the throughput? Because, without the nurses' buy-in and alignment, what's your view of that?
Well, the nursing, we have great outcomes for our patients. So ultimately, our main perspective obviously is patient outcomes, making sure that we're getting good feedback from patient satisfaction rates, figuring out what is it that they feel that possibly is lacking within our center or our culture within the care that they're given in that center. And currently, we're within a national ranking of 98%, and we've been that way for over a year.
Wow.
When you're looking at, possible satisfaction rates coming back, the main part, it's good to key in on what they want. It's always information. Again, Ospitec provides that because you're getting, you know, that live feedback to the caregivers, so they know where their loved one is in the process. It's huge. The nursing staff is not having to be tasked with any kind of phone calls or anything else. They're still able to fully concentrate on that patient throughout their journey with them instead of taking moments away. So that for us is wonderful. We have, like Dr. DeCook said, we did over 3,200 cases this year. When it comes to any kind of rates that are coming back, our readmission rates are currently for the year like at 0.34%. Our infection rate is 0.65%. You know, our transfer rate is 0.26%. So overall, it's a great culture. Everyone nursing wise and techs and everybody else, they love working there. It shows in the care that they give each and every one of our patients, and the feedback is phenomenal.
You know, just to hammer that home, I think a lot of people think that efficiency means something sloppy, but it's actually the opposite, because it's really nothing to do with efficiency. It has to do all with the process, right? Once you start fine tuning each process, then actually our outcomes get better. So when you think about our infection rate, there's questions on the chat about infection rates. Why are our infection rates low? It's because we are fine-tuned on every single part of that process. Why are our complications low? That kind of thing. It's because the more you do of something, the more subspecialized you get, the better the outcomes. And every joint surgeon on this call, every neurosurgeon on this call knows the more volume you put through the system, the more your staff is all aligned, the better the outcomes. So that's, for us, that's the coolest part about this process, is that we're working on each individual process and our patients are benefiting from it.
I would echo that, Dr. DeCook. We've experienced that same thing in our hospital as we've gone through all this and got more precise on our processes. We've seen the same thing with our outcomes. Our transfer rate's gone down, our infection rate's gone down, all the same trends.
Yeah. And I don't know why our staff don't want to leave. I mean, we're working harder than anyone else, so I have no idea why Emily and the whole crew doesn't leave us tomorrow, where you could go to a hospital and do 3 cases. But I think a lot of it has to do with pride. We think that, well, we're paying our nurses more. We pay our nurses quite well, but it's not like we're incentivizing them financially to do more cases or anything like that. I think just like us surgeons, we are incentivized by excelling, by really contributing to something, and they know they're contributing to something special. And I think that's the main motivation for why we have staff that likes to work with us.
There's a sense of pride that comes with that.
Hold on, Emily, then Lacey.
There's a sense of pride that comes with that. So when you hone in on your processes, you become an expert, quote unquote, within that center, and there's a sense of pride that comes with that. And yeah, so people feel a lot of pride within work. So even though there's no major incentive and, it's competitive, but we're not doing any kind of major incentive as far as monetary compensation, that pride piece and that culture is high.
Lacey?
My only comment was, we do get some feedback. They say, you can't do it that fast. You can't do that many. You're cutting corners, something like that. That is couldn't be further from the truth. You can do things, processes quickly, and then you're not cutting corners. You're just doing things. The process is set and it's efficient, but we are certainly doing everything we need to do, as you can see from our outcomes. They're really great.
So Charles, Charlie, through the chat, I just offered Emily a job for about $500,000 to come to the South Bronx.
Take it.
South Bronx. So it's Yankees. It's Yankees, not the Braves. That's the problem.
And it
So
is the
I
Bronx.
apologize for
It
making
is the
that
Bronx.
offer. Yeah, it's the Bronx. Yeah. So I always have this thing when an innovation comes up, and I always ask the question of the innovators: if this came up first 15 years ago, would you ever imagine trying to make an OR the old conventional way? Could anyone, like Sanjay, could you imagine operating in a way that you're not doing now?
No, but I will say when I graduated 22 years ago, if I'd have told my faculty at USC that, hey, I'm going to do minimally invasive lumbar fusions in an outpatient setting, pedicle screws, interbody graft, and everything, they would have flunked me. They would have said, we're not going to graduate you because if you lost your mind. So, so the fact that we're doing more and more high acuity spine surgery in the outpatient setting is, really a testament to the technology that we have now. And I tell you, I absolutely love operating in our surgery centers. I mean, it's the best place to be. And then, adding in this technology like Ospitec, I can do 3 spines. I could do 2 cervical fusions and a lumbar disc and be out of there by 11:30. At the hospital, I'd be out of there by 6:30 or 7 at night if I'm lucky. So, I mean, the efficiencies we gain from being in the surgery center and having the Ospitec system driving our efficiency, it gives me back my most valuable commodity, which is my own time too.
I wonder if somebody, Matt Collins, you had a question. Matt? If you want to unmute. Otherwise, I'll ask the question for you. What's the cost of Ospitec? What does anyone know?
Yes.
People know.
It is Tommy Weilbacher. I think we have somebody from Ospitec on. I don't want to speak. I speak out of turn on that. It's actually not. It's surprisingly affordable. It's like, but anyway, if Tommy Weilbacher is on the call, he would be able to give.
No, we just, it's no upfront cost. It's all about the per operating room per month. And so it's really that one-stop shop of really these solutions, and continue just taking the thought leaders and taking those ideas and listen to the customers on trying to, expand that across the board and that per OR.
Dave Crawford had a question. Dave, you want to unmute and ask your question? I don't know if Dave is.
No, I didn't have a question. I just think to the point of incentivization, we, when you get efficient, the funny thing is there's disincentives, right? You want to work faster, you get done earlier, but then the nurses and staff get cut and they don't get their hours. So what we did at the surgery center when we opened it up was, okay, we want you to work hard and get paid and want to be incentivized. And so the comment I made to what was already mentioned was that you get a full day's work. I don't care what time we get done. Obviously, if there's overtime, there's overtime. But if you're supposed to work till 4 and we get done at 1:30 because you rocked it out, you get paid the same. So I think that was a great incentive. And we've got amazing staff that stayed there. I'm sure Charlie probably does the same thing at his place. And that's the way to retain staff, because in a hospital system, an employee system, very disaligned incentives. So I think if you can get the staff to be on board with like being efficient and want to work hard, because then they go home and work out and see their families, that's the way to go.
We ran into trouble a little bit with that because our pre-op PACU, they would tend
for
to.
sure. Yes. That's the issue. If the patient stays a little bit longer, they get a little angry at the circulators that are leaving early, but
it is
it's
a great idea.
It's
I like it. Yeah, but it is tricky.
We're talking a lot about the staff, but we probably should also be talking about the surgeons, right? So for me, one of the best thing is that time visibility in my operating room. So being able to look at each step and how long it's taking me to do each step, and having on the screen the next instrument and the staff is all aligned there, I think is really important. So we send out every month time metrics for all our surgeons, so they know exactly how long their cases are taking. They know how long their turnovers are, because believe it or not, there is a little bit of variation, based on how long the surgeon's, talking to family, dictating, so someone had mentioned going to a physician lounge. I mean, we don't let our physicians go anywhere near a lounge, right? I don't want them near a lounge because I want them operating and not making us money. So, I think we really have to look at ourselves as well. We often talk about setting expectations for staff and other things, but I think it's time, and at least in our profession, that we start having some expectations of how we're doing as surgeons. And I think one of the ways we can look at that is not only complications and proms and all that, but also how long it's taking you to do these cases. If it's taking you 2 hours to do a hip or knee, I think you got to kind of reassess and say, how do I improve as a surgeon?
I think it's a great point, and I want to sort of drill down a little bit on the people involved and getting buy-in and getting alignment. And I want you to put on a different hat, put on an HOPD hat, and application of these principles in a hospital, an HOPD, hospital outpatient department setting, or even a hospital 23-hour stay, or the ASC, I understand a lot of other incentives and fine, but a lot of people still operate in hospitals and have 24-hour days. What is some advice we can give people about getting people aligned in that environment with the lessons that you've learned there? And I don't know who wants to take that first.
Well, I live in the hospital quite a bit, unfortunately, still, so I could start with that. What I think the first step, if a hospital really wanted to become efficient to the point that it could handle Dr. DeCook's practice, by the way, 10 joints would take probably 5 days at Scripps Hospital in San Diego. not 1 day, but 5. So the first thing I would tell them is, look, you need to implement Ospitec, because you need real-time meaningful data on your operating room utilization, because Ospitec, what it does is once you have this data, it breaks it down by a digital dashboard, so you can see exactly how much time was spent, total time, and a breakdown in between each step: wheels in, intubation, timeout, incision, closing, and then turnover. And so you get a precise breakdown on every step of the process. So total time plus a precise breakdown. And it's not until you have that data that you can then improve upon the efficiency. Because if you don't know what you're dealing with, you don't know where the bottlenecks are. Is anesthesia taking too long between wheels in and intubation, or is there some other hiccup? So if you're not measuring the data, you can't manipulate or effectuate a change in the data. So again, I think the Ospitec is an elegant solution. I liken it to basically the graphical user interface for computers. I'm dating myself, but I remember the Commodore PC. You had to type in word prompts. It was kind of a pain in the butt. But then when Bill Gates came up with, you click on the Microsoft Word icon, all of a sudden it took off. This is an elegant, simple solution like that. It's really easy to implement, and then it gives you very meaningful real-time data on the exact timing of every surgery, every surgeon, and then you can optimize your operating room time utilization. And so, I think for a hospital to eventually get to the point where it could handle somebody like Dr. DeCook's practice, the first step they could do that, the only way it would be possible is to develop a measurement tool like Ospitec.
Charlie,
okay.
Yeah.
Yeah, I'll jump in real quick. It's interesting that any hospital I've ever been in, I've never had the nurse administrator come to me and say, "Can you do more cases at my hospital?" I've never had them say that. Right? Why is that? Right? Why are they not asking us to do more cases? This is so bizarre to me, because this is the only chance for hospitals to make money is in the OR. Right? Why is that? It's because it's run by nurses who I love, but have absolutely no idea how to manage the logistics of an operating room. They've gone through this long educational period of educating in patient safety, which is perfect, but they have no idea to execute on the logistics of the patient flow throughout the day. That's the brilliance of Ospitec. It gets rid of all that. You don't have to worry about that. You just turn the darn thing on and slap a bracelet on a patient, and it's done, right? That's what you need. That's why hospitals, I think HOPDs and hospitals will benefit from this type of technology, because frankly, we don't have the right people running our operating rooms. They don't realize that the OR is really a factory. We need people turning and burning, right? And to do that, you have to have somebody that's got this time data that they can act on. And for me, that's why I think Ospitec is absolutely not just going to be ASCs. It's going to be hospitals and HOPDs as well, for sure.
Interesting. Patrick Maiden asked a question, and I think it brought up a confusion. The Ospitec is really the software and the bracelet. It's nothing to do with the pod or anything else. That's just separate equipment, right?
Yeah, yeah, yeah. What
There's
Ospitec
multiple
does is,
systems like
yeah,
that. Yeah,
it just should alert you to all the new innovations you need, right?
right.
If you're having a hard time getting cases open in time, we realized, oh my gosh, 22 minutes is way too long. Let's get rid of blue wraps. Oh, here's a great innovation, SteriCube, right? It made us realize that when we started building new ASCs, we don't want those SBDs in our ASCs. Now we're going to do them all off site, right? So once you start looking at each individual process, then you start to really hone in on finding new ways to innovate.
Right, I agree with you. There are so many products out there, products like SteriCube, there's Turbit, there's this, there's that, but there's also other products that we need to keep on looking at that feed the factory, so to say.
Yeah.
And we don't know which ones will come out tomorrow. David Crawford had another interesting question. Dave, I'll answer it for you for a second. How much is it the who in creating a bottleneck? Like, for example, what if you have a problem with an anesthesiologist or which scrub tech, which nurse? Because, we've talked about the surgeon seeing their data. Do the scrub tech see their data? How do we deal with that? Because everyone wants to get, in our hospital, everyone wants to get scrub tech Bob. And if they don't get Bob, they say their day is shot.
It's so
Okay?
true. It's so true. And, I'll give you the perfect example. So we look at our PACU times and we rate that compared to our anesthesiologist of the day. So every anesthesiologist that comes through our centers, we know exactly, how long that patient is in the PACU. So we tie that back to their dosing of their mepivacaine. We tie that back to their nausea, vomiting, and their narcotic use, right? So because of that, we get bad anesthesiologists out, right? We get bad scrub techs out. Occasionally we'll make a bad hire or it's just not the right fit, and we get them out and we can justify it based on the data we have. So the who is probably most important, right? We all know there's some really terrible anesthesiologists, there's some terrible surgeons, terrible scrub techs, terrible nurses. Our job is to filter those over time and have, core team that really hums.
Hey, Emily, Arce, I'd like to ask you a question. Do you ever get complaints from the nurses in such a high intensity environment?
Absolutely. I 100% get complaints for the nurses. I would have to say at this point, which is surprising since we're doing 20 cases, it's actually the opposite. I honestly got more complaints when we were hitting the 14 to 16 case volume range, as opposed to the 20. And my only response to them was, they constantly wanted to complain about what was coming, but didn't actually experience it yet. So my response was, why don't we wait and see when this is going to happen? It's, usually it's a nice little ramp up period. We're doing it slow. I'm looking for staff, that all these things are taking place so that they, number one, know that they're in mind. They're not just left out there to do, 5 times the work that they were doing before, which eases their minds. So then their complaints honestly become less. And then when it actually happens and they have that staff that extra support that they were promised, and they see what it feels like, and they're still ending up with the same quality of life at the end of the day, they're still able to leave the facility at the same end of the day, go home to their families, eat dinner, do whatever it is that they want to do at the end of the day, because they're done with their work. The complaints honestly stop. So right now, I don't really have any. I would say, honestly, it's like maybe 0.1% compared to the thought of it when it was first coming and, you're change. Nobody likes change, right? So in the prospect of change, you have people who want to, and not just nurses, but techs also, business office techs, the whole facility. And I think at this point, they feel secure in the fact that even if we were to change yet again, they're on board and they feel like they're well taken care of, and it's not something it's not something being done to them. It's something that they are a part of.
I will say an important thing there is scared of change. one of the hardest things for an HOPD is you take the old culture from a hospital and try and apply it in a quote unquote outpatient department, right? And the problem is then you want to drag all that old organizational debt from the hospital and the ways we used to do things, and they're just resistant to change. So for us, what we've experienced, what we've seen around the country is a lot of these HOPDs really struggle because you try and bring the old culture of a hospital and the bureaucracy, and that never quite works out. So I'd almost rather start fresh with new staff, new everything, so there's no expectation, and that way you can start over.
Sanjay, I want you to ask you a question. Let's make believe, not make believe, right now you have Ospitec, I'll call it version 1.0. What's missing? What's missing from it? What's your wish list for version 2.0?
Great question. So the first aspect of the wish list is integrating electronic health records into the system, because then you can auto-populate all the timestamps and all of the data of the surgery center with an electronic health record, and that's being worked on right now, actually. So I think that in fact, there's a beta test of a system going into place now. So for me, the logical next step is integrating Ospitec into the electronic health records. The second issue, this was touched upon before, is that it's an extremely useful communication tool with all the family. So as as the nurse hits the tablet to say, okay, wheels in, the family, whoever is designated as a caregiver, is immediately pinged by text that okay, they entered the room. And then each step they're pinged automated, so that there's an automated system to notify the family of every step along the way, and that really saves the operating room nurses and staff a lot of time of stopping and making calls and making texts, which was alluded to earlier. So the next step that can occur is, now that you have communication, is a way to interface with both the patient and their family in the post-operative period. Like, okay, Dr. DeCook likes these types of ice packs, after this surgery. Would you like to order them? We, click here, or even informational things. Okay, it's not unusual for the first day after a cervical fusion to have some dysphagia. You may want to consider softer foods. If you have these symptoms, please call your doctor. So in each day along the way for a patient journey, since you have access to them, automating that message, and then tailoring that message, by surgeon preference. So those are my wish lists, is to bring in an integrated EHR, which is pretty much almost there, and to then tailor a messaging system and automate the patient journey after they leave, and automate it in a manner that's customizable to each surgeon. So if Dr. DeCook looks a certain ice pack, that message can be delivered. So that's the final step, would be automating the tail end of the journey as they're recovering.
It brings up a great point in that there are many software programs out there that are patient engagement programs with pre-op and patient engagement and outcomes post-op. You could either build it yourselves, or you could merge with somebody who already has that space. But what about, so that's just one idea. Now the question, does it interface with the Apple Watch or something like that for the surgeon? Like, how does a surgeon, how do you or Charlie, know what's going on? Do you look at an app? Do you get text messages? Do you look at the board, or does it go to an Apple Watch or similar? I'm not an advertisement for Apple here.
I personally look at the board, the digital dashboard,
Okay.
so, and they have that all through the surgery center, and you can also obviously get it remotely too. But for me, from a practical perspective, there's a dashboard, everywhere throughout the center. So it's like being at the airport and, looking at flight times. They have them posted everywhere.
Right.
Charlie, do you have a different way that you do look at that data?
Well, yeah, we get reports now, efficiency reports, which kind of really help us. For me, like, to give you an idea, like they sent us a new report on how long patients are waiting in pre-op before surgery. That's something, it was kind of off my radar, meaning I wanted a buffer of a few patients. We all have a buffer of a few patients that need to be ready to go back to the OR, right? But I realized that our times are creeping up on an hour. That means they're waiting in pre-op, they're like half naked, they're worried about the surgery. And we realized, well, shoot, do we really need to have like 3 or 4 people buffered? Do I really need to bring them in that early? You know, because patient satisfaction goes down the longer they're with us. So if I can shorten that 3 hours down to 2.5 by only having them be in pre-op for 20 minutes, well, that satisfaction is going to improve. So it's those kind of reports that we're getting now that, you know, things that I hadn't thought of before, that Ospitex shoots us now, that now we can, you know, start telling our patients to arrive a little bit later now, which I never thought I'd be able to say, you know, because we're so granular with how our average times are in pre-op.
That's great. We're miraculously 55 minutes in. It's mind-boggling to me how fast these go. But I would like to go around the horn with some comments from everyone. I'll start with John Bring. You want to give us some parting comments? Take as long as you need, but don't do more than 20 minutes.
I just echo a lot of what's already been said tonight of getting that level of transparency, creating that call to action of that unified front of how to drive change, and really looking forward. For us, it's just we're trying to figure out a way to position our whole organization around technology and creating a more predictable environment. And this is really paving the way for us, having that level of detail, starting to look at how do we're tracking the patient. How do we start looking at how we're moving our team members throughout the day and getting more information that way, or generating cues? So I think just having a tool like this just opens up so much opportunity on a lot of levels, depending upon where your organization's at, but it definitely provides you that accelerator to make change.
Great. Lacey, some comments, please.
Oh, yeah. Well, our goal originally was to try to give every patient the same experience, sort of similar to what Dr. DeCook was talking about. The first patient shouldn't be in and out in 20 minutes, and the 10th patient has to wait 2 hours. You know, that's sort of the hospital mentality. So we really did track, and we are still fine-tuning that. Our patients will frequently, they just say it's a well-oiled machine. They'll never feel rushed or hurried. That's never our goal. You know, we do have to turn bays over. Those 10 bays have to be turned over twice at least. So we look at those things, and the satisfaction of the patient, knowing that when we're telling them the right time to be here, we're telling their expectations and that we're meeting those expectations. So that's been the good part about all the data we've collected.
All right, Emily, from your new job in the South Bronx, what are your last some comments for us?
Sure. I mean, ultimately, the main focus would be the process, right? It's all about the process. You know, what is your process, and how is that process and its efficiencies, and ultimately, how is it able to create the outcomes that you ultimately are seeking? You know, again, with the staffing model of the room team and the patient team, right? If the surgeon is the bottleneck, then that means that if you separate it out from a room team of a surgical tech and, you know, an OR assistant, they're taking care of that surgeon, and the nurse can now concentrate with anesthesia to take care of that patient like they're always doing, instead of having to divide that and possibly delay anything. So I think that, along with the technology and the metrics and the data, to go ahead and look back at all these time measurements to see where you could improve and where you're excelling at are priceless.
All right, Charlie, some comments?
Yeah, just begin with the end in mind. I think we limit ourselves when we don't realize what's possible. That's why we enjoy having groups come watch us, because they don't, you know, they think, well, you know, I can do 6 a day or 8 a day. And it's because they, you know, hospitals have sucked the living life out of us, and we don't realize anymore what's actually possible. So begin with the end in mind. Think about, what do you really want to accomplish as a surgeon? How many in an ideal world would you want to do in a day? And then maybe 4 or 5, whichever it is. But if you start there and then work backwards to what you need, what kind of inputs you need to make that happen, I think for us, that's magical. So there's no defined script of this is how you make an efficient OR in your ASC. We don't believe in that. We think every center is going to find their own way. But once you make time open and available, they're going to make their own changes and make their own tweaks to improve the efficiency.
Great. And Sanjay, you want to bring us home for tonight?
Yes, sir. So I think that the one thing about Ospitec is it's also, in addition to being elegant and simple to adopt, it's also astonishingly inexpensive. The main hospital system here in San Diego that I do my inpatient work, they spent $500 million implementing Epic system-wide. And with Ospitec, you literally, there's almost no downstroke. It's a nominal monthly fee. And it really, I think if you're in a surgery center that doesn't have Ospitec, you can easily count on getting at least one more surgery a day in each room that you have. And that the ROI on your investment in Ospitec would be paid off, with just one extra, by doing one extra case a month. You're gonna cover the cost of Ospitec. So I think it's one of the greatest value propositions I've seen in medicine. And because I think maybe because a major company hasn't come in and bought it yet, but it's an unbelievable value proposition in terms of your ability to add more volume to your surgery center, and improve your processes.
Well, listen, this is a remarkable eye opener. The efficiency is legendary. For those of you who have been living under a rock, you could look at JOEI, Journal of Orthopedic Experience Innovation, and read Charlie DeCook's original 12 by 12 article. I know 12 by 12 is old school now, I've been told. But more importantly, it's one of the, I have to say, and I mean this sincerely, one of the most beautifully written business articles that I've almost ever read. It belongs in Harvard Business Review, and I'm glad Joey snagged it away from that. And another article is coming out, I believe, from them. I want to thank all our panelists today and the participants who chimed in on this, and I'll be able to say good night right now. Okay, so everyone can get back to preparing for OR tomorrow.